It's my pleasure now to introduce our keynote speaker, Dr. Chris Elias. I've known Chris since 1983 when I had just joined the faculty at UCSF, and Chris was an intern and then a resident at UCSF. He's come a long way. He went from UCSF, he did his residency in internal medicine, went to Thailand, came back. He's been at the Pop Council at PATH, and he's now at the Bill and Melinda Gates Foundation, where he oversees global development. And his portfolio is agriculture, emergency response, family planning, financial services for the poor, maternal, newborn, and child health, nutrition, polio eradication, vaccine delivery, and water, sanitation, and hygiene. It's a large portfolio, and the goal is to implement and take action where action is needed. Please join me in welcoming Dr. Chris Elias. Thank you.
Thanks, Tom, and thanks to all of you for being here this morning. We're not used to this kind of weather in Seattle, so I don't think you could get a crowd this big indoors in Seattle on a day like this, so thanks, especially on a weekend. And let me thank the UCLA Center for World Health and the USC Institute for Global Health and Charles Drew University, and in particular, the student committee that organized this conference, who I had a chance to spend some time with at Tom's house last night. And in particular, Anthony Bowie and Kara Factor for their leadership in putting this together. I really enjoy speaking at conferences like this because one of the things that's different than when I was in medical school is the energy. When I was in medical school, I was interested in what at the time was called tropical medicine. It subsequently evolved to international health and global health, now world health. I was telling Tom soon we'll have the Galactic Health Center here at UCLA. But when I was interested in international health as a medical student, people said, what's that? Or kind of shook their head or looked at me funny. And what's been interesting in my career is to watch the emergence of such tremendous interest in global health and development of issues that reflect, I think, the reality that we're increasingly an interdependent planet. We've always been that way, but our awareness of that has come together. And so your theme that you've chosen for this first annual conference of transdisciplinary perspectives is quite essential. Because the other thing I think I've learned in my journey from medicine through public health to now doing what is, given my responsibilities currently at the Bill Melinda Gates Foundation, which go from polio eradication to agricultural development, I literally couldn't do my job day to day without a transdisciplinary perspective. So what I thought I would do today is to tell you a story. And I was happy to see that the very next person on the agenda after me is talking about the role of narrative. Because I think telling stories is certainly how I learn. I think it's how many people learn. And I didn't want to give a formal lecture on a Saturday after many of you have probably been in class all week. So what I'm going to do is tell you, if I can figure out how to get to my presentation. Do I just push on the, just hit forward? Oh, okay. Forward. Forward. You can tell transdiscipline I like, but IT is one I've never really gotten my head around, even though my boss, don't tell my boss that. So what I'm going to do is tell you the story of a partnership that I had the opportunity to be very involved in. I've been at the Bill and Melinda Gates Foundation for about 4 years. Prior to that, for 12 years, I was the president and CEO of PATH, which is the Program for Appropriate Technology in Health, a Seattle-based nonprofit organization that works to develop affordable healthcare technologies for poorer countries. And this was a partnership that came together soon after I joined PATH in 2000. And I think it exemplifies some of the power of working across disciplines, because I think what happens practically in a transdisciplinary perspective is that while most people are still trained in a particular discipline, so to really actualize a transdisciplinary perspective in global health and development requires partnership. So, you know, we can have a transdisciplinary perspective, but to actually put it into action requires taking departments, institutions, organizations that tend to be anchored in one or two disciplines and working across a range of different, an ecology or an ecosystem really of different organizations and institutions to get an important goal delivered. And so I want to tell you the story of epidemic meningitis in West Africa. I just hit that maybe. There we go. So I didn't know this when I was in medical school, and I actually didn't know it until about 15 years ago when this project started, that there are 25 countries in sub-Saharan Africa that constitute what's known as the meningitis belt. Those are the countries colored here. The red countries are the hyperendemic countries that are particularly severely affected. They reside just below the Sahara Desert. And what the graph shows is that they have episodes of seasonal outbreaks of epidemic meningitis. Now, meningitis is, as I think most of you know, is an inflammation of the coverings of the brain and spinal cord. It causes fever, stiff neck, and ultimately untreated, death in many cases. And even treated, you see significant mortality. And this is a devastating illness for the countries of the meningitis belt, which are also some of the poorest countries in the world. And so what you see is a seasonal, typically in the winter as the dry mountain winds come off of the Sahara, and we don't quite understand why this happens, but there's a vulnerability to epidemic meningitis. And as you can see from the chart, you get dozens of thousands, sometimes hundreds of thousands of cases of meningitis. 10% at least of these cases die. Another 20% are left with hearing impairment or deafness or other neurological problems. If you go to the belt, you meet people. Everybody knows somebody who's had and died or been impaired by epidemic meningitis. So this was a problem, and it was, as you can see, a particularly severe epidemic with over 250,000 cases occurred in 1996. And the first thing I want to do is show you a little clip of a video about that epidemic.
It would be in 1996 with a very large meningitis outbreak that took place in sub-Saharan Africa with well over 250,000 cases. There were over 25,000 deaths and enormous amount of chaos that resulted from all of this. One of the largest meningitis epidemics ever reported.
Meningitis is a disease that affects the coverings of the brain and the spinal cord.
La méningite est une maladie beaucoup crainte dans notre pays.
It affects young people between 1 and 29 years of age.
Ça constitue de graves épidémies.
It comes suddenly. Patients can, within 24 to 48 hours, without prompt treatment, die.
This thing has to go away.
So, you know, this is a problem that the countries of the meningitis belt have been dealing with for a long time. 1996 was such a big peak in the epidemic curve that it prompted global discussion and action. And the leaders of the African health nations came to the World Health Assembly and said something has to be done. We need new tools to address and to prevent this kind of devastation. Because not only, the next couple of slides are to tell you a couple of stories about how the individual impact, right? So if we did, in understanding this problem, studies of individual families. This is a picture of a boy taking care of his brother who's in the hospital with meningitis in Burkina Faso. And in countries like this, where the annual income may be $300 per person per year, less than $1 a day, the average cost of dealing with a case of meningitis is about $90 to a family. And that involves getting them to a hospital, getting them what treatment may be available, caring for them, et cetera. $90 is 3 or 4 months of income in a place like Burkina Faso. And what we found is it's actually one of the most common reasons pushing people into poverty are these devastating health shocks. You know, we tend to think about the way poverty is discussed in this country. There's a poverty line, and we kind of think of that as a line that people are above or below. The reality is that people move in and out of poverty all the time. People and families and communities are responding to opportunities and moving themselves out of poverty all the time. But they're often being pushed back by things like illness, and if they're farmers, by drought and other weather events that affect their crops. So this was a devastating problem for individuals, families, and communities in Burkina Faso, the other hyperendemic countries, and indeed throughout the meningitis belt. In addition, this is a picture of a hospital in Burkina Faso. This is actually the makeshift shelter outside the hospital because the hospital was full. And so when these epidemics occur, they completely overwhelm the health system. So not only do people die from meningitis, but the entire health system effectively gets repurposed for dealing with the meningitis outbreak for 3 or 4 months a year. And so I was once in Burkina Faso in a district called Kaya, and I was reviewing the immunization records. It was not epidemic season, and they had perfect immunization records. They had really one of the best set of immunization records I've seen kept at a district health facility. And I was flipping through the pages, and then I got to January, and it was empty. And February was empty, and March was empty, and then in April it started again. And I said, well, where's the data for January, February, March? And they said, well, they looked at me like I was stupid, and which I was, and they said, you know, well, that was the epidemic season, so we were dealing with that. So we didn't do any immunizations, and we certainly, if we did, we didn't write them down. So you have, you know, one of the reasons you have measles outbreaks in these countries is that for a quarter of the year, nobody gets immunized because they're too busy dealing with this, which is a hospital full of sick patients and a courtyard full of sick patients. And so the impact on the healthcare system, we've heard this more recently with Ebola, how Ebola shut down what healthcare systems did exist in the Mono River countries. And as a consequence, more people may actually die in Guinea, Sierra Leone, and Liberia from malaria and pregnancy complications and other vaccine-preventable diseases than they did from Ebola. So that you have to think about in these fragile health systems, not only the effect of this disease, but the effect that the disease has on the entire health system. So, you know, there was a demand in the late 90s for a solution that came from the African health leaders. And here's an interesting story about that solution. This is data from England and Wales. Most of those epidemics, I should have mentioned, in West Africa occur from something called meningitis A. There are several strains of meningitis. Most of them, it's just a difference in which sugar coat they're wearing. And meningitis A has a particular sugar coat. And in Europe, it was meningitis C, basically the same organism, but with a different polysaccharide coat. And you can see that in the late 90s, there was a higher than usual rate of meningitis in the UK. And that meningitis was the meningitis B, the green line, which is kind of a baseline. And there's some unique things about the outer membrane of meningitis B that make it challenging from a vaccine approach. But then you could see they started having larger than usual cases of meningitis C. And as a consequence, and notice the y-axis here, right? This is 80, 120. These are absolute numbers. These aren't thousands. Whereas the y-axis for the meningitis belt was 80,000, 120,000. In response to 80 to 120 cases in the UK, several companies spent their money, their private sector R&D, they invested in developing vaccines for meningitis C. The market worked to respond to an important public health problem. And the meningitis C vaccine was introduced in the UK in 1999. And you can see that meningitis C went away. So the cumulative rate of meningitis is now what the rate of meningitis B is, or has been for most of those years. So we knew that taking existing science and technology, and what the technology was developing a conjugate vaccine for meningitis. That is taking the polysaccharide, which is what you need to target. But polysaccharide vaccines don't prompt as strong of an immune system. So if you take that and you bond it to a good carrier protein, something like the tetanus toxoid or diphtheria toxoid, that combined vaccine both stimulates the immune system and produces long-lasting, durable immunity against the meningitis vaccine. So that science existed. It's been applied for other vaccine constructs. And companies took that science and applied it, created a commercial, and more than one company did that, and created a commercial solution. The UK public health authorities bought that vaccine, deployed it, and solved their public health problem. So the science existed to solve the problem that Africa was facing, but nobody was using it. No company could see a profit in taking that science, putting it together for meningitis A in the way they had for meningitis C and deploying it in the meningitis belt, which is what led to the project that I want to tell you about, which is the meningitis vaccine project. And the goals of that project, modest as they were in 2001, were to eliminate meningitis as a public health problem in sub-Saharan Africa through developing, testing, introducing, and widely using a conjugate vaccine for meningitis A. So this was an attempt to take the science we knew existed and to apply it for a big problem in some of the poorest parts of the world. And I'll tell you briefly how that happened. That's the meningitis vaccine project. I should mention the meningitis vaccine project was a partnership between PATH and the World Health Organization that was supported by the Bill Melinda Gates Foundation. And in 2001, the Gates Foundation made a $70 million 10-year grant to that partnership to go out and produce a vaccine for the meningitis belt. And the first thing we did was to consult with African ministers of health, who, and we said, look, we have this project. We have $70 million from what at the time was a brand new foundation, the Bill Melinda Gates Foundation. It was one of the earliest, biggest, boldest bets the foundation made. And we're going to develop a vaccine for you. What do you think? And they said, you know, the only thing that would be worse than not having a vaccine would be to have a vaccine that we couldn't afford. Because if we have a vaccine, you know, more ministers of health have lost their job in West Africa over meningitis outbreaks than other things that, like measles and malaria that kill a lot more people, but are endemic and not seasonal and disruptive as meningitis. So they said, if you develop a vaccine and we can't afford it, and no one supplies it, and people know there's a solution and we can't get it to them, our jobs are even more vulnerable. So if you do this, when you do this, make sure it's affordable. And we said, well, what's affordable? And they said, like 50 cents a dose or less. Because at that time, in 2001, the entire health budget of Burkina Faso was $6 per person per year. So they said, look, this is important. We'd put a 1/12 of our budget against this. But we can't afford it if it's $3 or $4 a dose. So the first thing that the partnership, PATH and WHO, did was to go out and talk to the multinational pharmaceutical companies, all of whom knew how to do this. There were about 5 big vaccine companies. And none of them could do it at that price target. We did a cost analysis, suggested that if you use the most efficient conjugation methods and the lowest cost ingredients, you theoretically should have been able to do this at about a cost of goods at about 20 cents a dose. And we shared that data with them. And they said, yeah, but we don't use the lowest cost ingredients, and we don't have the most efficient processes, and it would be very hard to turn over our production processes just for this project. So one company did offer to do it for a vaccine that would have come out at about $3 a dose. We decided that wasn't enough, not affordable enough. So this very complex partnership came together. And a little bit like your opening slide with all the logos, this is actually just a sampling of all the people who wound up being involved in this. And long story short, what happened is that it took 9 years to develop this vaccine. We wound up transferring technology to the Serum Institute of India in Pune, India, which is one of the world-class vaccine manufacturers. They actually supply over half of the vaccines that UNICEF purchases for poor countries today. They're the single largest producer of measles vaccine in the world. They made a really good tetanus toxoid, so they had one of the ingredients already, but they had never made a conjugate vaccine, and they hadn't made polysaccharide. So we arranged for a transfer from Cinco Biopartners, which was a contract manufacturer in the Netherlands, transferred the polysaccharide, first made it, and then transferred and taught the Serum Institute to make it themselves. We transferred the conjugation chemistry. There was interestingly, the US FDA, not in the regulatory branch, but in their basic science labs, had discovered and patented a new, more efficient process for conjugation. We licensed that from the US FDA through the NIH into PATH. We then licensed it to the Serum Institute of India, and we built in the parameters about how to ensure a price of under 50 cents a dose at launch of this vaccine. Many others like CDC and AID covered some of the surveillance and preparation for sites. So we developed, tested, and by 2009 had shown the effectiveness and safety of a new conjugate vaccine for meningitis A. And when it launched in 2010, and that's what I'm going to show you next, when it launched in 2010, it launched at a price of 40 cents a dose. So by bringing a very transdisciplinary perspective and a very complex partnership between industry in both rich and poor countries, technology transfer, work between the civil society, nonprofit sector organizations like PATH and the UN through the World Health Organization, we were able to actually respond to the African leaders' demand for a solution for this problem. And this is one of my favorite pictures because I waited a long time for this. This is the vaccine arriving in Ouagadougou at the airport, where we had actually, since we were solving that problem, we thought we'd solve another one, which was that we actually developed this product so that it was more resistant outside of the cold chain, so that it actually can be managed in a controlled temperature chain. It doesn't require the traditional 3 to 7 degree refrigeration of most vaccines. And we went in to launch in Burkina Faso in 2010 the first deployment of this vaccine, which we decided to do at national scale, that is doing a mass campaign to reach all 1 to 29-year-olds, which are the high-risk population, over about a 2-week period. And I showed up there a few days before the launch and went to a health center. And I'm used to the discourse on vaccine hesitancy that dominates this country, certainly my neighborhood and yours, about, well, are vaccines safe, et cetera. And I went out to several districts and I asked people, well, you think people will show up for this vaccine? Is that going to be a problem? And the guy looked at me and he said, look, our biggest problem is crowd control. Because in the past, when we've had these epidemics, we've brought in the inferior polysaccharide vaccine to try and stop the epidemic, and we've often run out. So people have learned that if they wait in line for the vaccine, that we may not have it. So our biggest issue when we do meningitis campaigns is crowd control. Not, they had a village crier who went out and told them what time to show up, but creating demand for this vaccine was not the issue. And so what I'm next going to show you, they just taught me how to do this. So let's do that twice. That didn't work. Which one do I do it to? So that one? Yep. There we go. This is some footage from the launch, just to give you a sense of the pageantry that accompanied this vaccine finally arriving in Africa. How do you get it over? Up. Now you got to push go. Yep.
Today, December 6th, was really the day of the first introduction of this vaccine at public health scale.
And today the launch was by the president of Burkina Faso himself. And you can see that there's a lot of political commitment for this vaccine. You have seen presidents, ministers of here today to launch this vaccine. This one is preventive, and as you know, prevention is better than cure.
The government of Burkina Faso is committed to immunizing the entire population between the ages of 1 to 29 years in Burkina Faso over the next 10 days to 2 weeks.
Je suis Guéré Doma, infirmier diplômé d'État, donc au Burkina ici. Et dès que c'est venu, vous constatez que depuis le matin, nous sommes là. On ne finit pas avec cette foule que vous voyez depuis le matin. Nous avons pu vacciner hier 4916 personnes et approximativement, on aura peut-être les mêmes chiffres aujourd'hui.
The epidemics of Group A meningococcal meningitis will cease in Burkina Faso.
So, yeah, maybe I'll let you get. Great. So Mark LaForce, who was the director of the Meningitis Vaccine Project, that video was made at the time of the launch in 2010, and as you heard, his comment was, the epidemics of meningitis will cease in Burkina Faso. And he was right. You can see 2009, it's very thin, the peak from 2009, which was the year before the vaccine was launched. And these are the years after. And the epidemics of meningitis A in Burkina Faso have ceased. There actually hasn't been a single case of meningitis A among vaccinated individuals. There have been a couple of cases of people who wandered over the border from neighboring countries and who hadn't been vaccinated. But the problem, which had been, Burkina Faso is one of that handful of 5 or 6 hyperendemic countries. This thing, which used to devastate their health system, impoverish their people, went away. And it went away in many, many other countries as well. There was a tremendous amount of receipt, country after country in the belt. Let me find the right slide. This is the, why is it not? I don't know where the rest of Africa went. I guess it's very faint there. But this was the scheduled rollout over the last 6 years. So you can see the color coding is which year we introduced it. The vaccine's now been introduced throughout the meningitis belt. And in fact, we've seen epidemic meningitis A go away in the other countries. And so there's still some meningitis. There's actually currently a little outbreak, a significant outbreak of meningitis C. There were outbreaks of the other strains, but they were buried in these hundreds of thousands of cases of meningitis A. So now that they're gone, there are people working on similar approaches to other meningitis strains that do still happen in the belt and are still significant problems, particularly for the people and families that are affected by them. And so the same technology that led to this big success in meningitis A is now being applied to the other strain. So my last slide, in conclusion, the impact of this 15-year project, and I'm going to be 2 weeks from now in Addis Ababa to actually, with all my colleagues who worked on the development of this project, we're officially closing the project in 2 weeks from now in Ethiopia at a big celebration. So in 15 years, from start to finish, an incredible set of hundreds of institutions and partnerships, and a truly transdisciplinary approach to take the cutting edge of science and apply it to solving one of the biggest problems from a public health point of view in one of the poorest regions of the world. That's the excitement of what we can do today that we used to only dream of when I was in school and thinking about tropical medicine and international health. So this is just some numbers of the estimates. These are conservative estimates of actually number of lives saved, disability prevented. Really difficult and harder even to cost is how much this has benefited those health systems. They're still terrible health systems, as we saw when some of the countries in the belt were affected by Ebola last year. And they're not very resilient, and they're very susceptible to shocks. But at least the meningitis shock is not one they're having to deal with on an annual basis now. So thank you, and I look forward to some of your questions and discussion.
So that's an amazing story, and what a lovely story, and the difference it makes to the people living in that area. Are you now in the midst of similar technological development for other diseases? Could you tell us a little bit about that?
Yeah, I mean, at the Bill Melinda Gates Foundation, we're invested in lots of technologies for lots of diseases that will be hopefully as transformative as this one was. And there's a couple of different ways to think about technology. So in this case, we didn't have to discover new technology, right? You know, as I showed from that example from England and Wales, the science of conjugation chemistry, the science of vaccinology to prevent bacterial meningitis through this kind of a vaccine construct, that had been well funded and well studied by both governments like the NIH as well as companies in their commercial applications. Our challenge in this project was to take that science and apply it in the development of an appropriate and affordable solution for the meningitis belt in Africa. Some other problems, we have to invest in more discovery science, where we're really trying to figure it out, right? So if you take malaria, for instance, which you know, we've done a great job over the last 10 years of reducing mortality from malaria by about 60%, but still, you know, 400,000 or so people die from malaria every year. And we need a solution. Ideally, we need a vaccine. And malaria vaccine research is not something that either governments or companies spend very much of their own money on. So we're a big supporter of malaria vaccine research, trying to find, you know, if you will, breakthrough science. Same in HIV, a number of tuberculosis, a number of diseases that are big causes of morbidity and mortality, and where we don't quite have the solution set we need. And so we think through, by disease, where is there a role for catalytic philanthropy to step into a gap? And that gap may be in fairly upstream science. We fund some very upstream science, but it may be in more an application of science, like in this case, where we didn't have to discover conjugation chemistry. We could apply that, license it out of FDA and NIH. To then, you know, a lot of what I manage in the foundation is our portfolio of more downstream work, where we're deploying existing solutions to have significant public health benefit, whether that's expanding access to contraceptives. There's 225 million women and girls in the world who don't currently have access to contraceptives, but when you survey them, they want that access. So just expanding the availability of existing solution sets. You know, we're very, very close to a polio eradication. I'm hoping we'll get there this year, and we'll probably get there with this set of tools. But we're also investing in the next set of tools in case we can't. So, you know, we have a pretty diverse portfolio of transformative technology and investments kind of across a range of health and development issues.
Let me sort of go to a broader question. You know, especially for students looking at the global landscape, you've got all these players. You've got the multilaterals, you've got the bilaterals, and then along come Bill and Melinda with their fortune. I joined Warren Buffett in giving my fortune to them as well, so that my $10 a month. So what's it like? You're like the 100-pound gorilla in the international workplace, global health workplace. What's that like?
Well, we try to not be a gorilla.
I like gorillas.
Although I would point out that even gorillas are more gentle than most people think. But, you know, we certainly have had what I think is mostly a positive influence. I mean, just as, you know, I've been at the Gates Foundation, working at the Gates Foundation for 4 years, but I worked with the Gates Foundation really since the late 90s. Actually, when early in my career, I managed what was one of the first grants that the Bill Melinda Gates Foundation made back in 1997. And so I've kind of, in some ways, grown up with the Gates Foundation in global health. And I think that you can't underestimate the influence of this type of catalytic philanthropy. You know, in 2001, when the Meningitis Vaccine Project was launched, there was nobody else in the world that was going to commit $70 million on a 10-year horizon to develop a technology that might not work. And there were many times in that 10-year path where we thought it wasn't going to work. So the ability, I mean, Paul Farmer likes to say that Bill Melinda came in and did CPR on global health to get it going again. You know, he's probably right about that. I mean, you know, it instilled a new sense of vision. We were able to dimension our aspirations in a different way. You know, I like to say that, you know, in the 90s, I did a lot of work, as you know, in the field, and we would often do little pilot projects, and we'd finish it. The last paragraph of the paper was always the same, that we're very encouraged by these results, and if anyone ever put more money and political will into this, we could scale it up and make a difference. Well, I think what Bill and Melinda, and their crowding in of many other philanthropists, and they're challenging to other funders of global health and development, have changed that, where we now have, in many cases, the resources to scale things up. And so they kind of called us on that promise that if anyone ever put any money into this, we could make a difference. And not every project works, but we're certainly now aspiring to change things at national scale, whereas we used to be changing things in sort of boutique little pilot programs, and we could succeed, but then there was no way to kind of get that to the kind of public health impact at scale that we've seen with the Meningitis Project.
One of the things that that really sort of struck me in the discussion of the meningitis vaccine, you talked about how when families would get struck by this, or health systems would get struck by this, these were devastating shocks, devastating economic shocks. And I think that's a commonality around the world. We hear about that in the United States as well. Families experience devastating illness, and it really disrupts their economic well-being. Does the Gates Foundation work in that domain at all, or do you work with partners who work in that domain? Because it's one of the bad consequences of health problems.
Yeah, I mean, we certainly, what we try to do, most of our work is about trying to prevent those shocks. So a lot of our health work is about trying to develop vaccines, other prevention approaches that avoid that shock. We are increasingly, and we were probably a bit late in our evolution of the understanding that, you know, I think if you look at the history of the last 15 years of the foundation, at the beginning there was a real focus, almost an exclusive focus on new tools and technologies in a somewhat hopeful assumption that if you developed a new innovation, that governments and markets would take it up and use it. Turns out that the delivery system markets aren't any more rational than the development market, the product development markets. So you have to assist them. So in the last 5 years in particular, we've been doing more in trying to invest in understanding primary healthcare systems and their performance and how to improve them. But still, I would say most of our efforts are dedicated toward trying to prevent the shocks to the system. Partly because the ultimate development of health systems requires resources much beyond what we have as a even very large philanthropy. It's going to take the commitment of governments themselves, who actually do foot most of the bill through domestic resources for the healthcare system, the emergence of social health insurance programs, help from financing organizations like the World Bank and the regional development banks, and assistance, you know, the large aid flows from the bilateral donors for overseas development assistance. So we're now partnering with the bank. So for instance, we've developed with the World Health Organization and the World Bank, a primary healthcare performance initiative, which is really about helping, it's kind of a dashboard for helping poor countries understand the functioning of their primary healthcare system, what needs to be improved, supply chain and logistics, management, information, et cetera, financing. So we're beginning to do more in that, but it's a little bit trickier because in this case, you know, there were other, if you look at the logos, there were other funders that joined in this meningitis project, but most of it was funded by the Gates Foundation. In health systems, we're always going to be a relatively small piece, so we have to, it's harder work to figure out what's the catalytic role of a philanthropy in changing a big national health system in many of the countries, you know, big complex countries like Nigeria and Ethiopia, et cetera.
What are you most hopeful about that's next on the horizon in terms of, you mentioned polio, and you said this year. I hadn't thought it would be that soon. I thought maybe the next couple of 3 years. But what are you most hopeful about beyond polio that we might be able to get a grip on?
I hate this question. You know, it's kind of like, which of your kids do you like the most? You know, I think that one of the things that, I'll give you a couple of specific and then, you know, some general. I think that there are some important potential advances in key technology platforms. You know, I think getting, you know, harnessing the cutting edge of science, you know, whether it's nanotechnology, et cetera, to produce affordable diagnostic platforms. So much of what we deal with could be better dealt with, you know, better dealt with if there was earlier diagnosis, right? You know, and so, and we currently lack diagnostic tests for most of the things that we would like them for, where there's, you know, most of the places that in countries that are poor don't have central laboratories. They don't have the kind of facilities that a U.S. tertiary care hospital would have. So, you know, I think there's some very exciting opportunities for new science to be applied to creating low-cost diagnostics, which could be transformative across a range of diseases. I think that a lot of the genomic advances are going to give us opportunities to target, to understand who needs certain interventions and to target them. I think that's, you know, I'm also responsible for agricultural development. That's going to be transformed. The whole genetic gains movement in terms of increasing crop yields. And that's absolutely essential, given that the people who are going to be hurt by climate change first are smallholder farmers in marginal areas like the meningitis belt, or other places where 2 degrees, even if the world achieves its 2-degree cap, is going to drop maize yields across places like Kenya, et cetera. So we're going to have to innovate our way into more climate resilient crops, particularly for smallholders in Sub-Saharan Africa and Asia. And I think that the cutting edge genomics is going to give us, combined with computational biology that allows us to understand the genome and how to breed faster for greater success. There are similar applications in human biology. I think, but if I go to a more general level, I think one of the things that if you look across our programs has some commonality is bringing data and analytics to guide programs in real-time ways, in a way that, you know, much of global health and development was based on sort of dogma, right? This is how we do polio eradication. And that worked in 100+ countries, but it didn't work in the last 5 countries. And the only reason we're now close to polio eradication is that in the last 4 or 5 years, we've taken data and done deep analytics to understand where the vulnerabilities are so that we could target new interventions like the use of injectable polio vaccine to the most vulnerable groups, so that we weren't just going out and immunizing the same kids over and over and missing the same kids over and over. We're actually now figuring out how to chase that polio virus to its final lair. And that's, you know, that's because of an application of data and analytics. And I think we're seeing that across a lot of diseases. We'll certainly see that in the next 25 or so years as we chase malaria down. And so I think there's a real opportunity, especially if you think transdisciplinary, about how do you bring cutting-edge data science to bear on a continuous improvement of the response to some of these problems.
I'm going to conclude with a 2-part question. One is, what advice would you give to students aspiring to global health careers? And you work very hard. What keeps you going?
Oh. The first question's easier than the second. The first one's not easy either, but the first one is, my advice is always just do what you're passionate about, but keep an open mind to other things. I mean, I could never have predicted where I'd go, you know, even on a 2-year horizon. And you know, things like the Gates Foundation didn't exist when I was in school. So, you know, I started out in medicine, I shifted to public health, I wound up doing a fair amount of medical anthropology along the way. I mean, it was kind of you couldn't have predicted it. It was just kind of doing what I was passionate about and being open-minded. And being open-minded often means listening to people outside your discipline and department. We were at UCSF together. I did my internal medicine training there, and in that bubble of residency, the whole discourse was which subspecialty you're going to do and where, right? And so when I left UCSF to go work on the Thai-Cambodian border in 1986, people thought, what's wrong with him? And so, and I only did that because I was talking to people outside my bubble. So I think that's important to keep doing. And I think in terms of what, keeps you going, I mean, there's this whole, I think, not very helpful discussion about work-life balance as though it's some idea. It's a little bit like the poverty line. It's not actually a balance. It's you work really hard sometimes, and you travel and you're dead tired, and then you take time off. And so I think the balance doesn't come every day, but that energy for the work has to come pretty much all the time, or you wouldn't keep it up. So I think it's I guess I'd say be prepared to work hard, but then also remember to play hard. And I try to model this for my staff. I have about 425 staff at the foundation work for me. So I take my vacation. So what I tell them is take your vacation. When you take your vacation, completely disconnect, because it's not possible to scan your email and be offline. And then the third thing is to preferably do something dangerous, because it gets your mind off of work. So. My wife and I do a lot of mountain biking, which requires focus, because you can't be thinking about the polio, vaccine. You'll fall off the bike. So, take time off and do something dangerous.
Well, thank you. Chris, I've known you since 1983. Your career is distinguished. It just makes me glad. Two things make me glad. One is that there's people like you doing the work you're doing. Thank you very much for that. And that there's people like this in the audience ready to take up the next generation. So thank you all for being here. So we're going to take, okay, I'll let you cheer in a minute. We're going to take a 10-minute break. Well, Anthony says 5. I do everything Anthony tells me. So we're going to take a 5-minute break. There's refreshments out there. We want you to get to your breakout sessions so you have a full time with the breakout session leaders, and then we'll reconvene back here at exactly 11:10 for the debate on organ donation or organ purchase. So thank you all. We'll move to the next phase of this conference, and thank you, Chris.